And while we're waiting for people to join, can I just start by saying very, very sorry for the change in time. So you may have been notified about this only in the last day or so, in which case we really do apologize. But one of the many reasons we are so proud to have Gideon as our medical director is he does still continue with NHS duties, and he was on call this morning. So we really appreciate Gideon, you making yourself available, but that's part of the reason why we had to shift the time a bit for today. So thanks everyone for understanding, but apologies for that. And we do apologize for the maybe confusing communications, but are therefore even more grateful so many of you have been able to join us right now. So I think that's enough, probably small talk in. And what do you think? Filling the air, talking about virtual backgrounds, explaining the change in time, and thanking everyone for joining. Just to maybe get us going, my name is Eileen Burbidge. I'm the Executive Director at Fertifa. Hopefully most of you already know about the organization, but for those who may not be aware, we are London-based, but Europe's most comprehensive reproductive health benefits provider. Really, really pleased to be working with so many multinational UK-based corporates. And we're really, really pleased then, therefore, to support all of their employees as our patients and to talk then about putting in place a women's health strategy based on all of the, I guess, exposure and the experience and the learnings that we've taken from our client engagements. With that, I'm joined by Gideon, our medical director. I've already mentioned a bit about Gideon and again, how proud we are to have him as our medical director and the fact that we're able to steal him from NHS hours and his private practice from time to time. But Gideon, do you mind introducing yourself?
Yeah, hi, Eileen. Good afternoon, everybody now. My name is Gidon Lieberman. I'm a consultant obstetrician gynecologist and subspecialist in reproductive medicine, which kind of means dealing with fertility, menopause, all reproductive medical issues. I've been in reproductive medicine since 2002 and a NHS consultant since 2007. So been in the environment for quite a while. Most of my time is spent clinically dealing with patients. A lot of my time is spent dealing with teaching, education. And some of my time is dealing with webinars and question and answers. So that's me in a nutshell, Eileen.
Thank you, Gideon. And yeah, we do try and steal your time as much as possible. So we're grateful for that. What I should have been doing while people were listening to us introduce ourselves is actually also maybe start with a poll question to help us get centered and frame our conversation topics and our comments around what people really want to hear. So I'm just going to launch a poll here, which is to find out how many of you who've joined us today already have a women's health policy in place at your workplace. You'll see hopefully from the poll that we're asking whether you have one, you don't have one, and actually whether it's in place, which might be a bit sort of confusing or maybe too much detail then with the yes, and then whether or not then there is a priority for you to do it. If you don't, sort of, I think that was meant to be the case, cascading a bit. If you don't already have in place, if it's a priority for you in 2025. Obviously, this could be a very short webinar if the answers are yes to the first one and no to the second one, but we're going to see what people have to say. And then we've got a number of things that we thought would be useful to cover off. So I'll just give people maybe a couple more seconds. I will also mention a couple of housekeeping points while we're waiting for people to fill in their responses. The webinar is being recorded. And so if you, for any reason, might have to drop off or can't join us or stay on for the entire session, you will be able to catch up after the fact, and we will send that link around. In addition to that, we have both the chat function available for you that is currently set to only chat with us as hosts and panelists right now. So that is not to the rest of the attendees. And your name, unless you sort of block it out or obfuscate it, will show to us when you're asking us questions. So if you don't want to share any personal identifiable details, about maybe a situation or a question or circumstance with Gideon and myself, please be mindful when you're asking your question, or ask for a friend or ask for someone else in the organization. And then we also, in addition to the chat module, have the Q&A enabled as well. So please do feel free to use that Q&A module. Both Gideon and myself listen to ourselves, each of us respectively, but then the other as well, probably more than we'd care to. And so it would make it much more interesting if we, okay, I'll just speak for myself, but I wasn't really, I was just projecting there, Gideon. We'd really appreciate you helping us to break up the monotony of our voices if you have questions along the way. And of course, we're here because we're hoping that we can parlay some information that's of value to you. And we'll only know that's the case if you can engage with us and let us know along the way, or ask questions, whether they're to clarify a point or because you'd rather us talk about something else. So I think those are my housekeeping points. With that, I am happy to firstly end the that holding pattern slide, because I think we've started and we no longer have to have that saying we're starting 2 minutes. And I will end the poll because we've had great participation there, and I'll share those results. So with the poll, we do have that more than half of you said that you do have a women's health policy. Another 13% actually said you have one in place, maybe had one in place. A third of you, though, don't have anything in place. And then for introducing maybe additional elements or components of that policy, if you already have one in place, or introducing one full stop if you didn't, and you're one of the third of the participants who responded that you didn't have something in place to date, it looks like more than 3/4 of you are actually looking to add to or introduce women's health support and a policy in 2025. So thank you so much for answering those questions. And I think that does actually then validate, while we're here, hopefully helps us to establish and confirm for us that we are wanting to then go through some of these topics. What we wanted to first talk about then is, when, and I appreciate everyone sort of in good faith sort of helped to answer those poll questions, what we mean when we talk about women's health. And I thought, actually, Gideon, I could maybe put that to you as a medical professional. If someone comes to you and says, Gideon, what should I think about for a women's health policy? What is it that comes to mind, or would you recommend that HR professionals or corporate professionals think about when they're thinking about women's health and thinking about policies for that?
Yeah, hi, thanks for that. I was just thinking when you were talking there about breaking up each other's conversations, and actually how much benefit there is in group learning. And often we will make suggestions, and we're going to download you can download our policy. And there is this feeling of us to you, making suggestions, which we're going to talk about today. But I think there's a huge amount to be learned from, taking away from group learning about stuff that people know about and implementing in their own workplaces that we can take away and share. And I think it's really important. I've certainly learned over the past few years doing webinars with employers actually about some really great practices excuse me, really great practices that are in place that you just think, God, that's so obvious. Why haven't we thought about that before? So please, 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 if you feel you've got some things to share, minor or major, please let us know. Okay, so when we think about purely women's health policies, I'm thinking mainly about conditions that affect women. And these are, from a medical point of view, those that are related to reproduction. And don't forget that reproduction doesn't just mean actually fertility and getting and being pregnant. It's before fertility comes online, and then post-reproduction. So that's after women have either completed their families or just stopped having their periods. So when we think about post-reproduction, I think what we're talking about there is post-menopausal timeframe and everything in between. So I'm thinking, when I think about it, I kind of try and channel my thoughts about a company depending on maybe the main age groups that they have. So for young women, I'm companies that have lots of young women, I'm thinking about not getting pregnant. I'm thinking about contraception, thinking about STDs. I'm thinking about gynae conditions that are impact hugely on young women's lives, and this may be um, normal, natural menstrual history, heavy periods, painful periods, pain with intercourse. It may be related to a condition such as polycystic ovarian syndrome, which causes a great deal of upset and concern to young women. I might be thinking about pain syndromes such as endometriosis, a condition that we see a great deal of in gynecology, in general gynecology, and it has a wide range of effects: physical, psychological, personal, work-wise. So many women with bad endo will take time off work, and it affects women hugely in the workplace. It's a condition that, thankfully, on my social media stream seems to be getting more and more bandwidth. And it's really important that we think about endo in young women, women in their reproductive years. I think just when I'm thinking about that, I think it's when we think about endo, endo is often placed as a condition that happens to women in their 30s, 40s. But it's really important to know a very simple fact, and that's if a woman has periods, she can have endo, whether she's 16, 36, 42. Really important. And then I think about other conditions that are specific to women, such as fibroids. And then hugely important is perimenopausal and menopausal care. So there's a whole wide range of conditions that affect women, and it's really important that you consider these, obviously, and just kind of maybe tweak your policies just to maybe have a little bit more emphasis, just depending on your age groups.
Thank you. I think that's a great breadth of different issues to consider, and I appreciate you flagging them all. I think there's a couple of things maybe I'd just add because, of course, everyone needs to prioritize, I suppose, and wants to make sure that they focus on the highest impact things. I would sort of remind, and I know you know this because we talk about it so much within Fertifa, that even if we would be drawn to considering age groups and what's generally applied or maybe relevant to people, just like you said, women of any age could potentially, have or suffer from endometriosis. We also know that while some people might think of menopause for women later in life, that some women in their 30s will start with perimenopausal symptoms. And obviously, those whose mothers have had early menopause might actually go through that earlier as well. And then, of course, there's early menopause brought in by, surgical intervention or other medical health or medical and health issues, right? That could be as a result of endo or something else. And so it's also, I think, to pick up on something that you said, yes, we want to think about what typically applies to an organization based on the health of their, the age of their population, but also to be mindful that a lot of these things affect, people of all ages, right?
Absolutely. And I was this morning, I've just been seeing a couple of patients whose periods are stopped less than 40, and that's 1% of women. You don't think about that. 1%, 1 in 100 women, periods will stop before they're 40 because of ovarian decline, and it's likely that those same self women started having symptoms 4, 5, 6 years prior to that. And that's really quite an impact. And remember that 5% of women, 1 in 20 women, will stop having periods before the age of 45. They'll probably start to become symptomatic late 30s. And as women age after 45, that number of women whose periods stop actually increases. So I think one of the things that I notice now, which is really good, is that people are becoming more and more aware of menstrual disturbance, perimenopausal changes earlier than they used to. We had a client this week who contacted us, and she'd become made aware of perimenopausal symptoms because of an article a diary article in one of the papers, and it's really good. But I agree with you. We should have these groups, but really it's just to focus on conditions can happen at any time. I'm mindful that 10% of women will have symptomatic endometriosis, 10% of women will have symptomatic PCOS type symptoms. So these things are really important. And the case this week of the woman becoming aware of perimenopausal changes really made me think about what I hear from a lot of patients. And that is, Gidon, if I had known about X, I would have done Y. Now, I always say to people, well, we can't live in retrospect and we just got to take up where we are now and go forward. But it's this education of gynae problems that we really should be talking about and really should be highlighting. Now, they may be of less significance to some women and more significance to others, but this awareness, this constant discussion and reinforcement that gynae problems are common, women's health problems are problem, women's health problems are common, and we should just be putting that message out again and again and again in whatever format is appropriate to you. But I agree with you. It's just that awareness for all these conditions, and thankfully, there's help. It's just if only I had known. And I think it's our job as health professionals, I think it's our job as employers to make sure that people are aware of it.
No, absolutely. Thank you so much. And I think to help drive that last point home and this awareness and how maybe prevalent it is or how it can impact people, just to remind people of some stats, because I suspect given, those who have joined us, it's probably a very well-informed, well-researched group already, given that they've, responded that they're looking to put something in place this year anyway. But to recap, you've already mentioned, for example, 1 in 10 women will be diagnosed with endometriosis here in the UK. We know that actually more than half of women, 55% of them based on studies, will take time off because of endometriosis. And on average, they have 9 days lost of productivity a year. This is from Endometriosis UK. We know that, and you said this too, normal, or I guess would call it regular or, menstrual health can cause lost days of productivity as well. We know women will take up to 4 or 5 sick days a year because of what maybe other people would constitute as regular menstrual issues or pain. We know that 70% of women who have PCOS, which you'd mentioned, Gideon, they actually go undiagnosed, and nonetheless, 1 in 10 women probably do have it. We know that more than 2/3 of women will at least have one fibroid at some point in their lifetime. I remember, I didn't realize I had fibroids until I had a scan for my first pregnancy, for example. And then more than 1/3 will have a long-lasting health problem or challenge after they've given birth. We know that there's 2 to 3 times higher risk of mental health disorders with women relating to their reproductive health. And we know that 40% of women who experience high levels of menstrual pain will just carry on trying to work through it. So I think those two are kind of related. And actually, based on our own surveys, almost 1/3 of women have said they've considered leaving their work because of perimenopausal and menopausal symptoms. So just to drive the point home that these are very impactful topics and health concerns that people are trying to manage, cope with, or even understand or get diagnosed with. And I just want to draw in, somebody kindly actually mentioned in the chat to us, and I don't know if you've had a chance to see it, that as we've talked about and we've tried to help people think about some specific issues or topics to actually mention within a policy, they've offered the fact that their own policy actually just mentions that they'll support women who experience adverse symptoms even without a formal diagnosis, because they know that so many women suffer from symptoms before they get to that diagnosis. And I've just mentioned how many won't get diagnosed for PCOS, how long. We know that it takes up to 7 years for a woman to get diagnosed with endometriosis, for example. So I appreciate that person flagging that, and it's a really good point, and probably a really good segue then into what we think should be included in a policy, and whether it's specific situations or topics that should be included. I think we've been mentioning them to help people be mindful of the broad spectrum, and that we're not just talking IVF, for example. We're not just talking fertility, or we're not just talking menopause. We're not, it's not just one single thing, which is why I wanted you to draw out some of the examples. But as somebody else has already mentioned, we should talk about sort of symptoms in general, adverse symptoms, pain. You talked about something as being a pain syndrome.
Yeah.
But what do you think should be included in the policy? Do you think a women's health policy is different or distinct to, say, a menopause policy, for example, which is separate to a fertility policy? How do you think they can play together? And again, from your clinical point of view, so not necessarily from an HR perspective, but clinically speaking, how do you think it's most supportive of women?
Yeah, thanks for that. I think it's really good. There's different models of healthcare in the world, and one of them, sort of two distinct models, would be a symptom-based healthcare model where you have a symptom, whatever it is. And then you might have another health model, which is diagnosis-based health model. A patient may have this problem, and this is how we're going to manage it. My feeling is that symptom-based healthcare is the most important thing, because our behavior, our lives are driven by symptoms, aren't they? So I might have pelvic pain, and it may be less important to some degree what's causing the pelvic pain, but more important the fact that I have it, that it's acknowledged, and that it's further investigated. And the reason I say that is because if you have a diagnosis-based healthcare system, such as I have fibroids, then you may have problems with your fibroids, but most women don't have problems with their fibroids. So I really like the symptom-based approach. I think it's a very low bar to entry. So people can take whatever action is required because of their symptom. And it may be that it's time off work. It may be going down a pathway such as FATIFA to trying to find out why they've got the pelvic pain. So I really like the symptom-based approach, because there's very little qualification required by the individual to gain entry into that. So a patient wouldn't have to say, I've been to the doctor and I have X, and so therefore I need time off work. It's much better that the employee says, I need time off work because I've got pain, or I have a menstrual disorder, or I'm not feeling great. And that's a very low bar to entry. And I really like that. I have to say, I really, really like that. And then I would suggest that once that switch has been turned on, that then there cascades a pathway of investigation and appropriate treatment, so the individual can be supported in however it may be. And coming back to symptom-based approaches, it's much more than just the binary of time off, time at work. It's much more than having access to healthcare. It's kind of like how we look after people. And symptom-based policies should consider gynae and menstrual disorders. Okay, so I'm not just talking about, that having a fan on the desk. I'm talking about having flexible work models where people can be close to the loos, they can be close to exits, they can be close to facilities where they might keep clothes or personal items that can support them through whatever journey they're going to. And that also then comes on to the symptom-based way of writing policies. So there's easy access and easy access to pathways, such as being able to say, I need an hour away from work. I need to go for a walk. I just need a bit of fresh air. And actually being able to access on symptom-based situation is really important. And it doesn't matter kind of what that symptom is. It's just that you switch on the process just by flagging you've got the symptom. And I really like that. And then I was I know I'm just dominating this for a second, but then I was thinking about one of the things that I've learned from doing webinars with employers is actually this concept of having small portions of time that people can just say, I just need a rest half an hour, I need a well-being half an hour just to get my head together. I just need it while the painkillers settle in. I need it. So these small allocations of time, I think, are a really important thing to happen. So I really like the symptom-based approach, really important. And I think it gives that low bar to access, and then we can cascade further interventions from there.
Thank you. I think that's a great way to frame it, and I would wholly agree. I think that a lot of times, though, if an HR manager wants to organize information in a easy to find way, they might want to have keywords. They might want to be able to also sort of signal that, again, these topics, it's a safe space to have these conversations. Menopause shouldn't have a stigma to it. Talking about endometriosis shouldn't have a stigma. And so you might want to call out specific things. But I appreciate that your point is from establishing what might be included in a policy. So accommodation, adjustments, time off, those things, ideally best led from a clinical point of view, your clinical point of view, from a symptom perspective, especially as has been already flagged, lots of times people don't have the diagnosis of what's causing the symptoms. But I can also appreciate that from a, putting in place and articulating, writing out a policy, you might need to refer to it as menopause policy, fertility policy, menstrual health policy, the things. But I assume we need to then work carefully at sort of weaving them together, or at least having them cross-reference one another, because maybe something's an example of something, or just a specific snapshot or case study of an actual policy. And somebody's mentioned in the chat, which I think is a really great point, there's a distinction probably to be made, and I might be unhelpfully using these words interchangeably, but between a women's health policy and a women's health strategy. And I really appreciate this contribution, so thank you. And, in this organization, they've got a women's health strategy, which covers 5 different strands and a lot of the topics that we've talked about. But then they've got policies, which might cover the policy points about time off, about, accommodation adjustments relating to specific elements of gynecological and women's health. So again, I guess this is just to offer a bit of best practice, but some examples to attendees or participants who are listening in about how you might want to approach putting in place a strategy. You may want to do your strategy first and then the policy. You may just want to go straight to the policy because you're being asked to figure out how to accommodate requests for time off. It kind of depends if you're going bottom up or top down, whether or not you're responding to what your employees or your people are asking for, or perhaps it's an executive who's going through something and says, you know what, this has helped me think that we should put a policy in place. And so there's lots of different ways to approach it. But I think, as you've emphasized, Gideon, the most important thing is to consider from a clinical point of view what the patient's going through, and what you as a medical practitioner would consider first is the symptom-based approach first. So then tying that all back together and thinking about practicalities, I just want to recap some of the things that you mentioned, Gideon. So you talked about time off, but that, and I like this, so I wanted to underscore it. I think I heard you say it doesn't necessarily have to be thought of as days off or even a half day off, does it? Sometimes it's an hour or just some time. And I think we appreciate the practicality of this if somebody is in shift work or working a certain type of job versus maybe desk-based work or office-based work. But in large part, a lot of times, what you're thinking about is that a policy doesn't have to be strictly binary, right? Talking about people taking days off or having an allowance or days. I wonder if there's other things that you think should be considered in addition to days off. Is it, access to certain resources, tools? Maybe it's a wholly separate topic we can come back to later is, how can managers support the conversation? How do people keep evolving their policies? But what else, is there anything else, I should say, you think should be part of a policy?
Yeah, I really like the time off and the the planned time off. And it was something that we kind of trialed in one of the clinics that I run in the NHS, where I know this may sound a bit way out, but it was actually quite popular. And what we would do is during a very busy morning clinic in the NHS, which typically runs between 9 and 1 or 8 and 12, etc., we would allocate everybody 15 minutes to get up and to go and sit in a quiet room without their phones and just have 15 minutes of just quiet time, and actually just allow everybody to have that 15 minutes of quiet time. And the results were spectacular in people's approach to coming to the clinic, people's ability to bounce back after that 15 minutes, slightly rested, and just like a small aliquot, a small amount of time can make a big difference, and it's really important. And I kind of just think as a bit like swimming or running, that you can run and jog away and swim away, but sometimes you just need to catch your breath for 15 minutes. And it's just the same concept. If you've got pain, or if you've got bad periods, or whatever's going on, you're flushing and just your mind's gone, and you've got really million thoughts going through your mind, that's kind of the time you just need half an hour just to get your head together and to let your physicality settle. And it's really important, these small aliquots of time. One of the things that I do like the idea about, and I think it's quite difficult to do in real time, but I really do like the idea, is having a supporter. And it may be something, and often these supporters are best in many ways. If you don't know them, it's often easier to talk to a counselor than a friend, because you don't know them and you don't have the baggage. So being able to sort of WhatsApp somebody and say, I'm having a bit of a bad day, and you're not expecting them to finish your tasks or whatever it is, but actually to say, I understand that you're having a bad day. We all have bad days, and bad days don't last forever, and it will get there. And you're just taking that time off. I've got pelvic pain. It's really bad. It's doing my nutting, and I want to rip out my insides. You just need somebody to say, okay, well, it's not going to go on forever. Take some time. So I think having a supportive person, a buddy at work, I like the idea that you don't know who they are, and like it's both ways. They don't know who you are and you don't know. I like that, but that's quite difficult to do. But I quite like that. And then, as you say, Eileen, it's actually resources, and it we're all addicted to the screen, so it makes it easiest that a pathway in my own mind would be like a bell you ring on your desktop, and it gives you some ideas. So I think there's lots of things that can be done digitally to support, but I kind of think actually just taking a bit of time and just having a one-to-one with somebody, because we all like a little chat, even if it's for 5 minutes, just to make ourselves feel a bit better.
Thank you. So it's having support, whether it's through a supporter, whether it's through a buddy, maybe it's a line manager. It's obviously we've talked about the time off and how that can be binary, or it can just be a few minutes out of the day. How do you answer the question if somebody were to ask again from your clinical point of view, how many days off a year do you think is reasonable to include in a policy to think about women's health issues, whether they're pain or otherwise?
I think there isn't, when I'm asked that question, I struggle a little bit, because I want to say, I want it in my sort of very liberal approach to life. I want to say as much as you need. That's kind of what I want to say. But I also appreciate that people have got to work. My experience is that women hate taking time off work for reproductive reasons. They don't like it. They don't want to put their head above the parapet. They don't want to be seen as somebody who appears to have insert negative adjective A, B, and C. Okay, they don't want to be that person. They want to struggle through and get out. And I've never met a woman, never, who wants to take time off work just because they're taking time off work or taking time away because they have to, because they can't work. And I think when you talk about how much time people need, well, people need time off work to deal with whatever's going wrong with them so that they can work. And implicit is that is there's an answer that's not a right answer for everybody. There's an answer that's right for that employer. There's an answer that's right for that individual. I've been very interested in the debate that's currently going on about working from home. Really interested in it because in all the debates that I've seen in the media, there's nobody. Well, I might have missed it, but nobody has raised the point about women's health in this debate. I mean, it might have been, and I don't watch the news all the time, but actually there's debates about childcare, but there's actually no debates and mentions about women's health. So I think that when you're talking about policies, it's not just the amount of time, and hopefully I've explained that I think time should be flexible in its allowance, but actually where the where the individual works and how they work. So, and in a lot of branches of holistic medicine, we talk about how somebody does something, where somebody does it, and why somebody does it. And it's kind of asking these questions will lead you to the answer that's right for your company. And there isn't a right answer for everybody, but there needs to be an allocation, an acknowledgement that should be set aside for this.
That's brilliant. Thank you. And I think you stole some of the points I was going to make when we were going to wrap up. But no, I think it's absolutely right. I think the most important thing, and maybe I should have opened with this versus saving it for the wrap up, is when thinking about a women's health strategy or a women's health policy and anything that might be included in either of those is the signaling that having something like that in place or the discussions about that and what that signal represents and means to the people within the organization, which is that we're acknowledging these things, we're acknowledging the existence of these points to consider, the impact on people's productivity, and we'll come to mental health as well. And so I do think that's really, really helpful for you to stress. And I did sort of set you up there because I know you don't like that question in terms of, you know, how many days off should be considered. I'd like the chance to reiterate again that your emphasis would be on not just strictly on days, doesn't just have to be days, it can just be time out, it should be flexible, and that component could be hours, it could be subset of hours or days. I will offer that across our client base. I think we've seen a range, generally between sort of 5 and maybe 10 or so days, depending on how the company has ascribed that to either symptoms or specific diagnosis or topics such as menopause specifically or not. I'll also mention that somebody that's on the webinar for us has chipped in to let us know that they're introducing a policy that'll have no restrictions or no limits on time off, and it will just be needs-based and individually centered on that person and their needs. But they're also taking that chance to sort of monitor it as terms of whether or not there's going to be guardrails in place or you need line manager approval. And that was the other point I was going to make. So our first kind of takeaway is that any of the work that's done for a policy is to acknowledge, address, and signal to an organization how important it is. The second thing is to start the conversation, and that none of these policies or decisions should be set in stone to be never considered again. It's a starting point, right? And it's important to have this dialogue with your people, your organization, hopefully in advance of putting together a policy, ask them what they value, what they would anticipate, what they'd expect, what they would hope for, start to get their feedback, try to introduce something to start, because that's nothing better than to start and see how you go, and then test and learn and look to revise that as you go. But we talked about the time off. We've talked about having supporter or support network of resources in place. You've talked about how people work and considering that. And I love that you mentioned specific examples about, you know, access to windows, fresh air, exits, sitting down or standing up and thinking about all of that. And so I think those are all points to consider. and determine. They don't all have to be specified. I don't think they all have to be fleshed out in order to introduce policy. I'd actually encourage, again, that that not be the case. Doesn't have to be perfect. Don't let perfect stand in the way of good or progress. But that these are all the different things that we see that come up, and again, from your clinical view. I want to now sort of shift slightly to something that you touched on, or at least made me think about, which was mental health, and how, we're talking about physical health or physical ailments and symptoms that manifest themselves physically because of different things that happen with women's reproductive, hormonal, and sexual health, organs and system and hormones. But mental health, and I think I wanted to actually share a stat. You probably already know this, Gideon, but in fact, we know that according to surveys, an individual's line manager or their manager impacts their mental health more than doctors, therapists, sort of professionals that are meant to support mental health, and actually to the same degree as their spouse or partner. So individuals are therefore affected, and it's not just in the workplace. Their mental health, their well-being is affected as much by their line manager as it is by their spouse, by their partner, and much more than a mental health professional or clinical professional can impact. And so I think I wanted to mention that because it is so important to send the right signals to an organization about whether or not a line manager is going to be, if not actively supportive, at least mindful, aware, cognizant of talking about these topics or supporting individuals through it. We know that two out of three women will feel uncomfortable disclosing any kind of sort of, well-being impact or mental health sort of challenges that they might be going through. But we know that actually 20% of British workers have taken time off because of mental health. And so I'm tying this back to your comment, Gideon, about sort of return to work and that debate. So I have seen, but my algorithms probably do feed me a lot more about sort of women's reactions. I have seen comments on, or the commentary on, return to work policies and how they might set back women disproportionately to men in the workplace if there's a consistent drive towards return to work, and how it's not just because of women's health, but also potentially because of the fact that women disproportionately bear care responsibilities, not just for children, but also for adult or other family members' care. So, the mental health aspect and how much managers in the organizations influence that is just something I wanted to open up. And I didn't know if you had more to add, or if I've sort of taken all the stats and you're sort of there to say, yeah, I told you so. But is there anything else that you'd kind of add to that?
Yeah, thanks for that. I think you can't look at a person and completely separate mental and physical well-being, because they're together, really. You can't separate them. So whenever somebody has a physical issue, it will have a resulting psychological or mental health issue. And as we all know, vice versa, stress. I feel it in my bowels, doctor. I get a headache when I'm stressed. So we know it works both ways. And when I'm teaching about mental health and talking about mental health to a group of people, I say, I'm not going to ask how many of you've had mental health struggles and mental health challenges, but those who don't acknowledge it maybe really aren't being open with themselves, because everybody on this call will have had mental health challenges. Sometimes they're quite marked and sometimes they are less severe, but everybody will have them. And the 20%, I think, actually is an underplay, because I think that a lot of physical reasons for people taking time off work actually start with mental issues. And I was just thinking a little bit about what you're saying about your feed. And I don't know when that stat was taken about effects on mental health, but I know, just being a little bit older, that there's very little about social media that improves people's quality of lives. And I think a huge amount of mental health education should be, or needs to be, directed about the negative effects of social media on people and of women and young people especially. I think it's really important. And then just flipping back to the other things that we could do for the menstrual health, I kind of just think education to those people, to people who don't have reproductive health challenges, is really important. So it's understanding about it, and to make sure that those people who aren't challenged by reproductive health issues have an understanding that it does happen to lots and lots of people. So the stats of 10%, it doesn't really matter. Just lots of people are affected, but also lots of people aren't affected. And there's education of everybody that there are these challenges. The same thing with mental health that affect everybody, and just to make sure that there's a greater level of understanding in our workplaces about these challenges.
No, thank you so much. I think you're absolutely right. I think it's important. I wanted to make this webinar, we wanted to talk about practical tips when people should take into what they should take into account for writing a policy, but I think it's really important to keep in mind and not forget these principles about mental health and everything else. Just kind of, again, hoping that we're getting that balance right between the two. Going back to the practical, you had alluded to when we were talking about support and resources, in addition to some of the things we've already covered, like a supporter, someone who can listen. You kindly mentioned something such as Fertifa, but obviously, I would be the first to say that we have lots of fantastic peer organizations in the sector. We're not the only company that obviously looks to support well-being for individuals' reproductive health. But what do you think, out of whether it's Fertifa or somebody else, what other types of support can we offer? Do you think it helps, or does it actually, lead to more anxiety, for example, if testing, if diagnostics is offered, if consults are offered, if assessments are offered? And it's probably a leading question, but I'd really value your medical view on that, clinical view.
So I think one thing that's definitely happened over the past 15 years, I suppose, maybe even less, is the ability for individuals to access test at home or testing by non-medical people. And my feelings about this is that you can be really careful with the information that you gain, and people get results, and it's power, and it's how people control that information. That power is the most important thing. So I'll have people who have tests done without adequate explanation, understanding. And those tests are actually, for most of the point, a bit useless, and unless it comes with that understanding without that explanation, because they're just numbers or figures or scans. And it's actually really important. So that's the one thing. It's accurate discussion with somebody who knows what they're talking about the results. And I frame it in those quite firm ways because I think it's really important. And if you're not going to have a test explained to you, then it's kind of useless. So I think it's really important and can be dangerous. I've seen lots of people who turn up to my clinics, both in the NHS and through Fertifa, who've had investigations done, and they can be falsely reassuring, or they could be falsely reassuring, and they can reassure that, and they can cause concern when they're actually okay. So I think there's this thing really important that if you're going to do diagnostics, that it's coupled with an explanation at a route where people actually understand and are explained to what these results mean. A result for me of X, if Eileen has that X result, may be completely different. So there is huge amounts of difference for one result between one person and another, and you have to put it into the clinical situation. That's really, really important. And I do worry about people having tests and investigations because it's easy to do. You just tick a box and you pay it, but actually not having adequate support, diagnosis, and therapy based on. So I do really worry about that a lot. There was another point I was going to make, but I can't remember what it was. About what was your question, Eileen? I was going to make something.
Well, I can try and recap, and you'll probably think of something because I maybe overly paraphrased. But I think maybe what I'll take a chance to do, and you'll cut in, is I'll clarify, because I've alluded to Fertifa, you've talked about the testing kits. At least what we can do at Fertifa is we can provide access to employees, or to your employee base, for example, to testing kits, to diagnostics, as well as to assessments. But of course, that's always then framed with, it may not always be Gideon, but it could be a nurse consultation, it could be the care advisor. And for those who don't know enough about Fertifa, I'm not going to go into an advert, but I am putting down through the chat that we are actually hosting a live demo next week, actually, if people want to see how employees could access, you know, our patients do make access to their clinical advisor, how they can book in appointments, how they can discuss access to testing kits, and have conversations like you were describing in a medical context with their medical history, as an individual should consider any results or testing. And so I wanted to flag that. I don't know if that's brought it to your mind. The only other thing I'll do while you're still thinking then is to answer one of the questions in the Q&A, because somebody has asked, how do we think it's best to communicate a new women's health strategy or focus to employees? And I think that actually it does depend on an organization's internal comms, but I do think, you know, there are now, thankfully, never done, but more and more awareness days coming up that you could always sort of anchor to, whether that's International Women's Day, whether that is menopause awareness, whether that is fertility awareness, whether that's endometriosis awareness, or, you know, of course, there's Men's Health Month as well, and Men's Health Days. So that's what we would suggest on that. I've also just realized the time. So again, I don't know if you thought of the last point you wanted to mention, because I never want to cut you off. I don't want to not talk about it, because you've always got such great things to say. But I do want to make sure that I touch on a couple of more things, because I usually promise to give people time back before the next hour. But if you didn't have anything else, I'm also, oh, does that mean you do? I'm also putting down the chat that if it's helpful for people, we do have what we would describe as a gold standard. So we would welcome any feedback, of course, input, and like some of the data points that have been shared already in the chat by some of the attendees as to how this can be improved. But we feel that we have, you know, a nice women's health policy template that could be useful for helping. And then the final thing I wanted to do was to launch a poll, but I won't do that if you had something else you wanted to say, because I do want to.
Super quick.
Yeah.
Super
Go.
quick. So at the beginning of the discussion, I was talking about different medical models for how to difficult medical models, and we talked about the symptom-based health care, and then we spoke about the diagnostic-based healthcare models. And this is now what we're entering into a different phase, is the test at home diagnosis health model, where people get stuff done at home, and then it goes down a pathway. And I think there are huge risks to this, as I was just intimating. And the importance, if you're going to go down that model, is just make sure that it's safe by ensuring that those results are discussed with somebody with insight. So it's like this third model. I'm not a huge fan for obvious reasons, but if you're going to do it, just make sure there's adequate support.
Thank you for that. I think it's a great way to end. And actually, I'll just then bookend it with a final poll. Might look like we're fishing for compliments. We're not necessarily. So we would be happy to receive no's, as long as you don't mind getting in touch and giving us feedback, or posting feedback in the chat. If there's anything anyone wants to share. You see both of Gideon and my names on the screen. Our email convention at Fertifa, like most companies, is first name dot last name at fertifa.com. You can always get in touch at inquiries@Fertifa or info@fertifa.com to get in touch with us. We will hopefully be in touch, particularly if you answer yes to question number 2 of this final poll. But we, you know, hosted this webinar to offer you what we hope is a balance of practical advice, but based on, you know, medical, clinical perspectives that Gideon brings with his years of experience, in order to help workplaces support their employees better. And the reason we care so much is your employees are our patients, and we do see ourselves as an extension, hopefully, of, you know, a people or an HR team in supporting individuals' well-being. And we hope that we can do that and reflect all of the positive intentions that you might have as an HR professional in conveying that to your employees, and to help them bring their best selves to work. So we really appreciate everyone joining. Apologies again for the change in time because it was changed, but because we were planning to do it anyways. I mentioned in housekeeping, this was recorded, and we are happy to share the link for anybody who didn't get a chance to see all of it. And like I said, we remain available for any follow-up. We're really keen to engage further with any advice, suggestions, like I said, feedback of how we can improve, or maybe if we can improve our calendar that I just shared down the chat, the policy template I've shared down the chat. If you join for the demo, any feedback that you see in the demo next week, or anything that Gideon and myself said or might have said today. And with that, my final thing is to thank Gideon very, very much. It's always a pleasure talking to you. I didn't mean to suggest that I listen to you too much, because I could listen to you all day. I suspect you hear from me too much of annoying things, but especially today, like I said, because you're doing NHS cover unexpectedly or non-standard for a Thursday. Really grateful for your time as always, and your really balanced views as a medical professional, but also thinking about the patient, the employees first and foremost, and what that might mean to them, and of course then to their HR professionals. So thank you, Gideon.
Yeah, thank you very much, Ali.
Thank you, everybody. Have a good rest of your days. Bye-bye.
Bye-bye.